Okay, Dr. K, today we are here to talk about the myths about multiple sclerosis and to bust them.
Let's do it.
Great. Can you just tell us a little bit about yourself, your experience with this disease, kind of your background story?
Sure. So my name is Dr. Marwa Kaisey. I'm a neurologist and MS specialist at Cedars-Sinai Hospital in Los Angeles. And my time is spent half taking care of patients with MS and the other half doing research on MS and also teaching other physicians how to take care of patients with MS. And my research is specifically focused on the diagnosis and prognosis of MS, so developing better tools to get people diagnosed more quickly and to give them a better idea of what might happen in their MS course in the long run. I have a family member with MS, so my association with MS goes back to when I was a teenager, when my mom got diagnosed. She had a pretty severe course, tried lots of disease modifying therapies, and after I became an MS specialist, I actually went back through all her records, and it's really remarkable to me how well she's done, given how aggressive her disease was in the beginning. Didn't know all that as a teenager, of course. And through a long route, kind of found myself interested in neuroscience, specifically as an undergrad at UCLA, and thought about being a neurology researcher or neuroscience researcher, but didn't love spending my day in the lab with cells and mice and nobody to talk to. So I went to medical school and became a neurologist and then really loved being in the MS clinic. I loved the patients. I loved that we had disease modifying therapy. So there was a lot more hope in MS clinic than in some other parts of neurology. And it was just a wonderful fit.
That's great. I love to hear that, especially I was diagnosed when I was 10 years old, and that was a very long process, right? Taking that to our next question, because you mentioned DMTs, disease modifying treatments. We don't have a cure for multiple sclerosis. So there's not a lot of treatment options out there, right?
It really depends what you mean by treatment options. So you're absolutely right that we don't have a cure for MS, although there's a lot of work being done to find one. But we can't cure a lot of things in medicine if you think about it, right? There's an old joke that the only two things you can cure in medicine are a broken leg and a pregnancy, which I don't like because pregnancy is not actually a sickness or a disease. But we can't cure high blood pressure. We can't cure diabetes. We can't cure a lot of these things, but we can treat them and we can manage them and we can improve the quality of lives of people living with them. So we can do all those things for people with MS. And, I was talking about my mom back when she was diagnosed in the late 90s, there were like two or three medication options. Now there are over 30 to put that in perspective. So, and as that's a long time is what that's over 20 years. But as far as science and medicine goes, that is lightning quick as far as how quickly we've developed new treatments and options for MS. And there are new ones coming out almost every year. And that's always good news because the more options, the better for every patient because it gives us a higher chance of finding a good fit. So we do have a lot of treatment options, even though we don't have a cure. And these treatment options all have one thing in common is that they're meant to stop the disease in its tracks. So none of them turn back the clock on the damage that's already happened. They're preventative tools to help save the brain and spinal cord tissue that's still healthy and help preserve the function that that person has. So that's pretty good, even though we can't cure it. Now, I will put a little caveat on what I just said in that we have all these amazing treatment options, is that they're really for the relapsing part of the disease. We don't have good treatment options for the progressive part of the disease. And if you think a little bit about that, the relapsing part is a lot of inflammation. In medicine in general, we have a lot of tools for calming down inflammation. We have steroids, we have all these tools for rheumatologic diseases that we can kind of borrow from in MS. But if you think about the slowly degenerative diseases that we have in neurology, Alzheimer's, Parkinson's, progressive MS, we don't really understand what's driving those, let alone how to stop it effectively. So we have excellent tools for relapsing MS. We don't have a cure for MS, and we don't have great tools yet for progressive MS.
Yeah, I think that a lot of people, just because they assume there isn't a cure, aren't aware that there's actually treatments out there. Also brings me on to actually my next question. For people who don't have many symptoms, and their disease is dormant, does that mean that their disease is not progressing at all?
That's my patients ask me this questions a lot, and they'll say, well, I feel great. Do I really have to be on these medications? You're telling me about all the risks and the side effects. Is it worth it in my case? And there used to be this term, maybe it's still around, called benign MS. meaning MS, it's dormant or not active, as you're saying. So the person feels good, they have no symptoms, they have no relapses. And you can even go so far as to say their brain MRI doesn't show any new lesions, right? It just kind of stays where it is. So by all looks of it, it looks like the disease has kind of gone away. As we get better tools for looking under the surface, we get better markers of subtle inflammation. We got better MRIs that pick up smaller lesions. So we are learning that this is not really a common entity. It's probably very, very rare if it does exist. So we used to think that 5 to 10% of people with MS have benign MS. Maybe they don't need treatment. As our tools are getting better, that number is shrinking. And we're finding that most people with MS do have underlying inflammation. Now, there's also this concept of reserve in the brain, right? So every brain cell is super important, but some of them do kind of overlap, and you can get away with losing quite a few before you ever have symptoms. So that is part of why we do MRIs regularly, to kind of look under the surface, make sure that there's nothing under the surface that's active, that's inflamed, that could cause symptoms in the future, and catch it before it gets to that point. So a lot of my patients, you would never know they have MS. They're actors, they're lawyers, they're moms, they're traveling, they're living really full lives, and they're living with MS, but without having those symptoms that are visible day to day. They're not necessarily walking with a cane. They can see okay. They don't fit that stereotypical disability kind of picture. And that partly is because we're managing it. We're keeping the MS in check. It goes back to that whole concept of, well, we can keep people looking and functioning well and prevent disability in the future with the tools we have. But really, to do that, I would usually say that that's because of treatments and trying to go after that kind of quiet type of MS, and not because that's just the way the disease would function without the treatment.
Okay, that makes a lot of sense then. So we have some basic questions I feel that need to be answered. One of the first ones is multiple sclerosis contagious? Is it genetic? Are parents going to give their child multiple sclerosis if they have it?
Yeah, these are really good questions. I get these all the time in clinic. A lot of my patients are in their 20s, 30s, 40s. They're thinking about starting families or wanting to get pregnant, or have their partner get pregnant with their child. So there is some genetic component to MS. So in the general population, it's about a 1 in 1,000 rate of MS. 1 in 1,000 people have MS. So it's not super rare. It's not super common. If you have a first degree relative with MS, meaning a parent or a sibling who has MS, your chance goes up to 1 in 50, all the way up to maybe 1 in 25 with the right risk factors. So still not that common. We're talking 2 to 4%, even if you have a parent or a sibling with MS, but definitely higher than that baseline 1 in 1,000 rate in the general population. So there's definitely a genetic component to it, but it is not as straightforward like autosomal dominant. If you remember back to your Mendelian genetics class in maybe middle school or high school, it's not like that, like every person in the family is going to have it. But there's the genetics kind of increase your baseline risk. There's a lot of things that increase your risk though. So you're talking about, is it contagious? So I hope not, because I see like dozens of MS patients in my clinic all day. So then I would be putting myself at risk without protection and wearing gowns and all that stuff that we would do for a viral infection. But you bring up a really interesting point, is that there is this whole question around the Epstein-Barr virus, or EBV. And that's the virus that causes mono, or kissing disease, where you get the inflamed lymph nodes and you're super tired. That same virus has been almost proven, I would say, as much as we can, to be necessary for somebody to develop MS. So it's not a one-to-one causation. So if you get EBV or mono, that doesn't mean you're going to get MS. In fact, 95% of the general population has been exposed to this virus, and clearly not 95% of the population has MS. But if you haven't seen this virus, you're not going to develop MS. So part of it is genetic, part of it is your viral exposure. Part of it is probably your other toxins in your environment. Like if you smoke, or your parents smoked in the house, that can increase your MS risk. So I think this is part of why we still don't understand the cause for MS. It's probably because there's not one single cause. It's probably a perfect storm of viral exposure, genetic risk, environmental exposures, where you grow up, that will determine whether you develop MS or not.
Yeah, that makes a lot of sense. And I've heard a lot about that Epstein-Barr virus. Question is, speaking of genetics and children, is about women in pregnancy. Can women with MS get pregnant? And if they do, are they able to have the baby? Is it safe to have the baby?
Yes. So yes, absolutely. Yes to all of those questions. And we have a board in our clinic that has baby pictures of all of our patients who've had babies, and it's really cute. So if you ever want to come see that, you're welcome to. But it's absolutely something that is possible, that is safe, and the babies are, no extra health risks to the babies. So part of this is again getting the disease under control. So when I see a new patient and she's recently been diagnosed with MS and it's a devastating time in her life, it's very scary, but always, even through all that, she's still thinking, well, I really want to be a mom, and we're actually going to start trying like in a year or two. And she kind of sneaks that question at the end because she almost feels guilty thinking about that wish, and in the middle of all her diagnosis and symptoms. And so kind of always bring it up myself, even if they don't, because I know it's in the back of a lot of people's minds, even if they don't even have a partner yet. It's just like some dream they have, and they're scared that now it's not possible. So it's absolutely possible. I would recommend people get the disease under control first before trying to conceive. So if you're just getting diagnosed, I wouldn't start trying to get pregnant at the same time. I would figure out your diagnosis, get on the right treatment for you. But as you're picking the treatment, tell your doctor that, hey, I would like to get pregnant in the next year or two, because that's going to affect which treatment you choose.
That
So
was my next
yeah.
question too. Can you, if you are on treatment, can you get pregnant? Can you stay on treatment while you're conceiving, like throughout the whole pregnancy?
It really depends on the treatment. So there are some where we have enough data now where we feel safe saying you can stay on it until you know you're pregnant, or even throughout the pregnancy. There's not many. Most of them we would take you off, and it would just have to be in a way that's safe, or potentially switch you to a medication that's a little bit safer for pregnancy. So as far as the FDA goes and the official recommendations, really it's Copaxone is one of the ones that's considered to be a little bit safer. And some people will even keep their patients on, some physicians will keep their patients on throughout the pregnancy. The rest, some of them are known to be bad for the babies, like Obagio, for example. So I don't actually prescribe that one to my patients who are trying to get pregnant, because that might be dangerous to the baby. And this is from the tough thing, Nicole, is that there's not been a lot of money invested in women's health and women's issues. So we don't get a lot of studies on pregnant women. We don't get a lot of studies on nursing mothers. And that's a real disservice to our female patients.
Mhm.
And we're left with basically like data that's been cobbled together after the fact, right? So someone happened to get pregnant on this medication, or they gave it to, for example, chimpanzees or monkeys, and they kind of see, is it a problem in animals? Probably a problem in humans too. So that's what all this is based on, is kind of cobbled together. So we're never going to get great studies with large numbers of purposely exposing pregnant moms to drugs, right? Either we're not going to do those studies. But most of the drug companies have pregnancy registries where they will follow the hundreds or thousands of women who happen to get pregnant on that drug, see what happens to the pregnancy, to the baby. All those registries, other than Obagio that I mentioned, which was an animal study, all those registries have shown that these drugs are probably fine. To some respect, but they're really, really tiny numbers, and they're not enough for us to feel comfortable putting our patients on these drugs. So it's a long way of saying it's really individualized as to which treatment you're on. But this is a conversation that every patient should have with their doctor before they start trying to conceive, because they can either, again, take you off the medication in a safe way, switch you to something else that might be safer, and the planning needs to be a part of it. And so typically one question I have in my checklist, especially the first time I'm meeting a patient, is what contraception are you using? How are we being safe so we don't have accidental pregnancies? And then what's your pregnancy plan? What can I help you to figure out so that you can make your dreams come true in that respect safely? And the other part of your question is, okay, somebody is pregnant, they have a healthy pregnancy. What is the delivery like? I think, is that different in moms with MS? And I still get questions from OBs and people taking care of my women who are pregnant, saying, okay, like, do we have to do a C-section for this patient, or can they like not get an epidural if they really want one because of their MS? And the short rule of thumb, again, everybody's different, but the short rule of thumb is that women with MS should be treated just as everybody else is when they're pregnant. There's really nothing that they can't have. There's nothing that they must have. So all these decisions that go into delivery planning with your OB, the same as anybody else.
Yeah, that's great news. And another common misconception is about wheelchairs and MS. Does everyone eventually end up in a wheelchair? Is that just kind of what their disease is going to lead to? How many people are in wheelchairs?
So short answer is no, not everybody with MS is going to end up in a wheelchair. So MS can affect your ability to walk in three ways, three main ways. It can make the legs weaker. It can make the sensation different, so you can't feel where you're moving your legs, and that can make it really difficult to walk. And it can also affect coordination. So balance, coordination, putting your feet where they need to go, staying upright. So for those three main reasons, people can end up in a wheelchair because of MS. But they certainly don't have to. Everybody's disease course is different. And I just saw a patient yesterday in clinic who was newly diagnosed. And what I tell people is, please try not to Google as much as possible. There's a lot of good information out there with MS, but there's a lot of bad information, first of all. But even the good information may not be relevant to you. So somebody being diagnosed in like 1993, 2000, 2003, even 2013 is not the same as somebody being diagnosed in 2023. So our diagnostic tools are better and our diagnostic criteria have changed, which means we pick up MS earlier. So we can treat it earlier. That we know makes a big deal. Even a 2-year difference in how early you start treatment can make a big deal in your long-term prognosis and your disability levels. Our medications are better. So if you start on better medication fit for you early on that really controls your MS from the get-go, that can affect your disability and prognosis levels in the future. So again, the treatments are different, the diagnostic tools are different, the criteria are different. And so, MS today is not what it was 10, even 5 years ago. And that's part of why I love being in this field, is because we're always improving so quickly, and it's always for the benefit of our patients. But that makes it hard for me to give you a number as to how many people with MS end up in a wheelchair, right?
No.
Because that target is always moving, and for the better, it's always kind of coming down. So I've heard my patients with MS who've had it for a while say, I hated going to the doctor's office, or I hated going to a support group. If they're young and otherwise look good on the surface, right? They're walking normally. That's all that really means, is they look good on the surface. They're not using a cane or a wheelchair, because they saw everybody else in a wheelchair, and that kind of got them down. And so it's really interesting to see the generational shifts between people who've had MS for a while and people who are getting diagnosed now, and then even those who've had it for a while, what their MS was like, and how that course has been. It's always changing, and it's too difficult to generalize. And so I ask my patients to try not to take as somebody else's story and just imagine that's going to be their story exactly.
Yeah. Is MS deadly? Because a lot of people will say, like, oh, my grandfather died of MS, but what does that really mean?
Oh, I see what you're getting at with this. Yeah, I've heard that too. It's like and it's usually like an older relative who was diagnosed well before we had treatments. So the short answer is no. It's pretty rare for us to put that somebody passed from MS. Even before our high efficacy treatments that we have now, the average life expectancy for somebody with MS was only 7 years shorter than the general population. With the medications we have now, I imagine it's exactly the same as the average population.
Oh, wow.
Maybe a little bit less. Um, Honestly, maybe a little bit more in some people, because MS is a wake-up call to take care of themselves better. So they start eating better, exercising. So I can't actually confidently say that the life expectancy is less for people with MS at this point. And some people, it might actually extend their lives a little better because they take better care of their heart and
Yeah.
their body in general. But so that was,
Sorry. And it's not the MS that actually kills them,
yeah,
right? It's the MS
right.
association, whether it's the demyelination in the brain or something that ends up killing them, but not the actual MS.
Yeah, and it's not even the demyelination in the brain. It is something related to the MS. So if you're not able to move because of the MS and you're in bed all day, you can get a blood clot in your leg, which can go to your lung. you can get, you're not swallowing well and you're lying down, so that food can go into your lung and cause a pneumonia. So at the end of the day, it's not actually the MS, it's the physical disabilities that the MS can cause that can lead to other medical conditions that can be deadly. But like Nicole, this is so rare. This is so, I mean, I take care of patients all day. I can't tell you the last time that I actually had one of my patients pass from the MS directly. It's really, I tell my patients this all the time because I get this question even from young, healthy, newly
Yeah.
diagnosed patients. Is this going to kill me? And I love when they're brave enough to ask that because I feel like people probably are thinking that in the back of their brain and don't want to voice that. And the short answer is no. You are going to have to worry about all the things that the rest of us have to worry about, like high blood pressure, heart disease, cancer. Like you still need to do all those things to live a healthy life. You still need to get all your cancer screenings, just like the rest of us, because those.
I think you just cut out. I couldn't hear you for a second. Can you hear me still? Is it my microphone that's not working, or did I just not able to hear you now?
Oh, now I can hear you.
Okay, I can hear you now too.
Okay, good.
Sorry, what were we talking about? We were talking about it being deadly. And obviously you said you don't never really seen a patient die from MS. Oh, maybe you're not there.
Yeah, and did you hear the last part about you're frozen now too?
Am I?
Yeah, am I? Am I looking okay?
Yeah, you're a little frozen. Let me see if I can
Yeah.
try using this different internet, and I'll clip this part out. Yeah, you're frozen also.
Oh no.
Let's see. It's like
I'm on a desktop at work, so I'm not sure how to work it any differently.
yeah, I don't really know why it wouldn't be working right now. I'm about to call down to my tech fiance.
Okay.
Do you want to try? I can save what we have so far. It will automatically save. Do you want to try just coming back in? Oh, well, there you
Oh,
go.
did that work? Uh-oh.
Kind of. Am I frozen still too? If you can hear me, let's log back in. You seem to be fine now. Can you hear me?
I can hear you. You're just frozen.
Oh, I am still.
Oh no, you're moving, but it's like really it's not good video quality. But I
Okay,
can hear you.
let's log back in.
Sounds good.
Dr. K, a lot of people I've heard before talk about either family members or friends or knowing someone that died from MS. Is MS deadly?
It's such a good question. And I will occasionally get this question from patients in clinic, even the newly diagnosed, very healthy ones. And I'm so glad you asked because I think a lot of people have this question in the back of their minds, but they're too afraid to voice it, even to say it out loud. And the short answer is no, it is rare to die from MS. So the way that that would happen is there are very, very, very rare forms of MS that are hugely inflammatory in the very beginning of the disease. In fact, they're so rare and so unusual that I really think they're a different disease that we've lumped under the MS umbrella. Because typically MS in the beginning will cause relapses, but not something that will affect your breathing. Really, that's kind of the dangerous thing, right? Um, in very advanced MS, people who've had it for decades, who maybe didn't get treated or didn't have access to treatments and have had severe disability that's left them bedbound, they may not move their legs enough and get a blood clot that goes to their lungs and cause a deadly blood clot there. They may have to lie down and not be able to swallow properly, and that could cause a pneumonia. So things like that are technically fatalities related to MS. But again, very rare. And as we get better treatments, again, that's going to be more rare that people get to that advanced level of disability. The average life expectancy for people with MS before we had these great treatments was 7 years less than the general population. So I imagine that with these better treatments, that's a much smaller number. And I can tell you that I think for some of my patients where MS is a wake-up call to take better care of their body in general, they start eating better, exercising, their life expectancy might actually increase. Because what I tell my patients is that they have to worry about the things that are going to kill the rest of us too. Heart disease, high blood pressure, diabetes, cancer. Like you don't get a free pass from that stuff just because you have MS. And that's the stuff in the American population, at least, that are the leading causes of death, right? So I tell them you still have to get your cancer screenings, you still have to try to eat healthy and control your blood pressure and avoid heart disease and avoid diabetes, just like the rest of us. So really those are the things that just like the rest of us that are gonna kill all of us in the end most commonly, if we're lucky to live to that age. Or
Next question I have for you is, I've heard people confuse MS with cerebral palsy. Why is there this confusion? Are they the same, and what's the difference?
they're not the same at all. I hear MS get confused with myasthenia gravis, which
Or
is another
muscular
neuromuscular
dystrophy?
muscular dystrophy. Yes. And I think this goes back to the question of people being afraid to do surgeries on people with MS because they're thinking of these completely unrelated neuromuscular conditions that can cause trouble breathing and can cause trouble with anesthetic medication specifically. So I kind of understand, but they're different diseases. It's like pretty easily cleared up. So cerebral palsy is not an autoimmune condition. It's something that actually happens at birth during a difficult birth process for a baby. So the symptoms would start soon after birth and a few years after birth maybe, and there are a lot of variations in people's cerebral palsy, just like with MS. And sometimes there's cognitive effects and sometimes it's just physical, so they'll have stiffness of their legs, their muscles, spasticity when they walk. So yeah, somebody with cerebral palsy, they're going to have symptoms pretty early on in their life, and they're not going to have an up and down course like with MS. There's no relapsing remitting. It's a very different disease course. It's a different source of the condition. But I guess if you're talking about people who maybe have a spastic gait, as we call it, or stiff legs when they're walking, that can be an overlap between MS and cerebral palsy. Those two things can happen with both diseases. Even then, honestly, the gait looks a little bit different to a neurologist, so we can still tell the difference. But a lot of it is the story of like, when did this start? How long has it been going on? How has it progressed?
Right. I need to hear it. Everyone needs to know. What is the difference between fatigue and being tired?
Ah, yeah. So fatigue is the number one symptom of people living with MS. Even someone who looks fabulous, so you'd never know they have MS, they probably have some degree of fatigue. Tiredness is not really a medical diagnosis or a medical term, so there's probably overlap in there. And that's why when someone in clinic tells me, oh, I'm fatigued, I always try to kind of drill them down and say, what exactly are we dealing with here? Or if they say I'm tired, I try to kind of get more specifics. So typical classic MS fatigue is they wake up feeling okay. They go about their day. Somewhere in the mid-afternoon, they just hit a brick wall. Like they cannot do anything else. They have to go lie down on the couch. They either take a nap or they're just done for the day. So it's almost kind of like the spoonie theory, if you've heard that, like you only have a certain number of spoons to spend in the day. I usually tell my patients it's like having money in the bank. Like you sleep and you make all these deposits in the bank, and then when you wake up, you only have a certain amount to spend. Like you cannot push through
Yep.
when you're done, right? So that's typical MS fatigue. But then sometimes patients describe their weakness as fatigue, like, oh, I can only walk so far, and then my legs get really tired, and they describe that as fatigue. So that's like more of like a physical, specific to a body part kind of fatigue where you wear out your muscles. Um, Sleep, I'm a huge, like, I talk about sleep with everybody. Like whatever symptom you come to me with, we're going to end up talking about sleep. If you're depressed, if your memory's not very good, if you're feeling tired, it all goes back to sleep for me. So that's why I always start, is making sure that again you're depositing enough in the bank to start your day. So everyone needs 7 to 9 hours a night. Your sweet spot is somewhere in there. Mine is closer to 9, unfortunately for me, but
Me
like I
too.
know that if you too. Yeah. Like if I get 8 hours, I'm okay, but I really kind of need 9 to feel at my best. And some people can get by with 7. My husband thinks his sweet spot is 5. I'm like, that's not a thing. No, you definitely need more sleep than that?
So does my
So,
brother. He's at 5.
right. Yeah. I think it's a denial thing. Um, So I start there. It's like, all right, are you actually getting enough sleep? Is it good quality sleep? Because with MS, you have pain, you have spasticity, you have overactive bladder getting you up in the middle of the night. So are you actually getting that many hours of sleep, or are you getting up 5 times a night to go to the bathroom, right? Because that's going to interrupt. You need deep sleep. You need good quality sleep. It's not just about the amount of time you spend in bed. So we always start there is are you depositing enough? But even with that, people still can start fine in the morning and then kind of run out of their resources. So the next question is, well, okay, super common in MS. How do we treat it? How do we take care of this, right? It is very difficult to treat, unfortunately. There was a study a few years ago done at UCSF where they split people with MS and fatigue into 4 groups. And they followed them for a few months and they did all these measures on them, like tiredness scales and surveys. And they gave one group stimulants, like I think it was Ritalin specifically or something related to it. Another group, modafinil, which is a medication we sometimes use for MS and fatigue. A third group, amantadine, same. It's an old antiviral we use for fatigue and MS. And the fourth group just got placebo, like they got nothing. They got pills that had sugar pills or something. And they followed them for a few months. And at the end, they saw the 4 groups were pretty equal, like in their degree of how much better the fatigue got. They all got a little bit better, but it may have just been the placebo effect. So it's pretty discouraging because we were hoping like they would tell us one of these pills is like the answer to fatigue and MS, and we could just start doing that for everybody. So do I not prescribe pills for fatigue and MS? No, I still will try because every individual is different, even though the study showed us that on a population level, it's probably not going to help everybody. But I will tell you the one thing that every patient I've gotten to try has actually worked for their fatigue and MS is exercise. So if I can get my patients to exercise, and again, that's a tall ask for someone who comes and telling you they can barely move because they're so tired. But if I can get them into a good exercise routine that's not too much for them, they come back a changed person. They're glowing, they have so much more energy, they're able to do their work or take care of their families or whatever they need to do. It's a game changer. So that's something I really try to encourage in my patients with fatigue, which I'm not a workout person, so I can totally sympathize that they don't want to go do that, especially when they're tired. We're never going to have huge studies on this because it's not a money maker for the pharmaceutical industry like the pills are. So they're never going to invest that kind of money to study this. But the studies we do have show that my experience with my patients is true across the board, that exercise is really helpful for fatigue and MS.
That's fantastic. I try to get to the gym. Obviously, it's not always the easiest thing to do, but when
Yeah.
I do feel much better. So that's going to be it for us today. I wanted to thank you, Dr. K, for coming on and answering some of my questions. This was our multiple sclerosis myth busting Q&A. I really enjoyed it.
Thank you so much, Nicole, for the amazing questions. And thank you to the Emerging Leaders Board of the National MS Society that we're both a part of for getting us together. And happy MS Awareness Week.
Happy MS Awareness Week. Bye.
Bye.